delighted. We are delighted and honored to have Dr. Fitzpatrick from University of Delaware giving us a talk on the research she's conducting on long-acting reverse contraception. But before I introduce her, let me mention some housekeeping issues. So as usual, we will provide CME credits for our ID series. We will distribute the information via email to those that registered for today's event. But if you haven't registered yet, you can still obtain CME code information from Deborah Rees, and I'll give her email in the chat in a few minutes. So we have a very exciting presentations that are coming. The next one is a tech talk from Dr. Oskenak on December 2nd, and he will talk about workflow and analysis. Are we opening Pandora's box? And our next ID series is from Dr. Kutuli and Dr. Hachimonji from Nemours, who will talk about homelessness in high school. So please do not, please attend these wonderful presentations. So again, I'm really delighted to introduce Dr. Fitzpatrick. Dr. Fitzpatrick is Associate Professor in the Biden School of Public Policy and Administration at University of Delaware, and she's also the director of the Master Public Policy Program. She's also a research fellow at the Center for Financial Security at University of Wisconsin-Madison and a visiting scholar at the Consumer Financial Protection Bureau. She obtained a Ph.D. in economics from Syracuse University, and she has won multiple awards and honors, the most recent being nominated for the University Excellence in Honors Teaching and Mentoring Award in 2021. She has received funding from several foundations and other institutions, the last one from the Center for Financial Security and Research and Disability Research Center at University of Wisconsin-Madison. She has a large number of peer-reviewed publications and also research briefs and reports for foundation and state governments. So I'm really excited to hear this presentation, and welcome and thank you so much for presenting your data.
Well, thank you so much. So today I'm going to present some work that I have a really excellent team I'm working with, and this has been generously supported with an ACCEL pilot grant, and we are currently now dividing all the work we've done into some papers that we'll hopefully submit soon. And we're also extending this work thanks to an Embry Award with Dr. Marshall Ali that looks at more preventive care outcomes. And so hopefully we can talk about that at the end. But anyway, I'm very indebted to the ACCEL program for this work. And so the title of this project is, Does Increased Use of Long-Acting Reversible Contraceptives, or LARC, Have Unintended Costs? So just kind of a brief summary, as I'm sure you all know, most women are going to rely on contraception at least some point in their lives, and they have a range of contraceptive options that differ in a number of ways. First, how they work. Second, their effectiveness against preventing pregnancy. Third, their protection against STIs. Fourth, whether they require a physician approval or not, and how often they require a physician approval. And the last is whether or not they're reversible. So the most effective reversible contraceptive methods are LARC. So these include implants and IUDs. All LARC methods require a prescription and require a physician visit for insertion, but they do not require an annual prescription, unlike some moderately effective hormonal methods like the pill, injectables, the patch, and the ring. And we know from a lot of research that LARC methods are highly effective and cost-effective against protecting against pregnancy. In addition, right, because they are long-acting, they have higher continuation rates than other reversible methods. And so the research is really, really strong in this regard. But we have less evidence about what other behaviors that LARC might change. And in particular, we're interested in a couple of behaviors. So first, because they are so effective against preventing pregnancy, they may unintentionally encourage women to be less focused on using dual contraceptive methods. And in doing so, they might expose women to more STIs because women are less likely to use a dual method that protects against STIs. And secondly, because they're effective for more than a year, they may provide less of an incentive for women to attend their annual Wellwoman exam. And those obviously provide opportunities for women to receive screening, health counseling, including counseling on the importance of dual method use for STI protection. And there's been very little discussion of these possible responses in literature, with kind of a few notable exceptions. And so we really want to explore these potential outcomes. So just to give you two trends that are going on, and we're going to be looking at Delaware, but two trends kind of nationally is there's been a real increase in the adoption of long-acting reversible contraceptives over the last decade. So this is a chart from a publication in the American Journal of Public Health, I believe, that shows the big kind of trends in LARC use over the past couple decades. Secondly, there's also been an uptick in STIs, and so we're wondering if it's possible that these two are potentially related. Okay. We are going to look at Delaware, and Delaware is a really unique policy environment in order to examine these questions for several reasons. First, Delaware experienced a really large increase in LARC adoption due to both changes in Medicaid policy, state changes in with the DELCAN initiative, as well as changes at Christiana Care that may have really boosted LARC adoption. And so as you can see in this graph, Delaware went from kind of the below average in LARC use at the state level to after mid 2014, they started to Delaware has more LARC users in their Medicaid program than other states, right? So we have a lot of variation in order to identify any potential effects. Okay. So just to review the clinical recommendations and really help think about how this might tie to the practice of medicine. I'm sure many of you are well familiar with this, but just to review. So first, obviously, there's ACOG recommends annual Wellwoman exams, right? These are just opportunities for health screening and counseling, and obviously the exact care is going to differ based on the woman's health care needs. There's also recommendations for routine STI testing for chlamydia and gonorrhea. And this includes for women aged 15 to 24 years old that are sexually active, for women 25 and over, which those are high risk, and also at the time of LARC insertion. So at or around the time of LARC insertion, all women are supposed to be tested. So we're going to review these STI testing guidelines and see if they're being followed. Obviously, we don't know a woman's whether or not she's sexually active. We have limited information on whether she's high risk or not, but we are able to test based on look at these differences based on age. There's also a clinical recommendation to use barrier contraceptive methods to protect against STIs. In other words, dual use. And usually this means with LARC, also use a less effective contraceptive method that protects against STIs, notably the condom. So those are the kind of three clinical recommendations we're going to be investigating. We do not know a woman's non-contraceptive or non-prescription contraceptive methods, and so we've been using the National Survey of Family Growth to look at differences in these across women. Okay. So the data and methods, so we are using the Medicaid client data that Mary Jo McDuffie discussed last week, and these are administrative records of of Delaware Medicaid clients. So as she mentioned, these are very much like insurance records. We don't have all the information. We only know what was billed. We're going to look at the 2012 through 2018 period. And what we're going to do is we're going to create a panel data set, which means we're going to observe the same woman multiple times throughout the data set. And we're going to look at women age 15 through 49. So in effect, this equation that I'm showing you is comparing a woman to kind of a previous version of herself or a future version. So we're going to be able to control for a lot of things that aren't changing about that woman. And as she changes her contraceptive options, so whether she's using LARC, whether she's using less effective method, such as, but still moderately effective, like the pill, an injectable, other sorts of things, we can look at that, or whether she's using no method. And importantly, we are dropping from, even though it's not it doesn't change the results too much, we're dropping women that have undergone female sterilization once they have been sterilized, so that we can really compare women who are using no prescribed method, women that are using a moderately effective hormonal method, and women using LARC. And we're going to control for whether or not a woman gave birth during the year. There's a lot of postpartum LARC insertion, especially in Delaware. We're going to control for what age group they fall into. And we don't know a lot of the socio-demographic variables that are correlated with health, the social determinants of health, but we can match zip code characteristics of that woman and look and assume that she's probably like the other characteristics in her zip code. So we're kind of controlling for the environment she's in and her peers. And in some ways, we're also controlling for her likely characteristics. And with this method, right, we're really, again, looking at how women are changing their contraceptive methods and what that means for their outcomes. So I'll go over the outcomes we consider in this. So we're when we talk about any STI test, we're really only focused on chlamydia and gonorrhea. We originally wanted to investigate syphilis, but there were not enough cases. We're also going to look at whether or not they had a positive test. In other words, were they diagnosed with chlamydia or gonorrhea? And we're going to look at whether or not they had a Wellwoman exam in that year. All our data is annual, so we're just looking whether or not they did this within the year. We have roughly 50,000 women. The panel's unbalanced. We only have 150,000 observations over the 6-year period. So some women are in the sample multiple years, some only 1 year. Okay. The prescription contraceptive methods that we're considering are LARC, which include IUDs or implants, moderately effective methods, which is oral contraception, patch, injectables or rings, and female sterilization. Oh, I'm sorry, we dropped that. I'm sorry, I should take that out. And so we're doing a bunch of control variables, whether or not they gave birth during the year, as I mentioned, what Medicaid benefit group they are in, and their age cohort. Okay, so looking at the different methods, right? As you can see, most women, the most popular form of contraceptive methods is no method, which makes sense in this age group. Some women may not be sexually active. Some women may be trying to get pregnant. So there's a lot of reasons people may not use a prescribed method, but 70 to 75% of the sample is not using a prescribed method. That has slowly increased over time, just slightly. As you can see also here, the probability of using a moderately effective method has declined somewhat. And part of this can be some slight increases in LARC adherence. So we see that over time, there's been more women moving to no prescribed methods slightly, and more women moving towards LARC methods. If we look at the outcomes that we are considering, so about 30 to 40% of the women in the sample have had any STI test in that year, right? And that may or may not be related to adherence to clinical guidelines. It depends on their woman's age group and other risk factors. Right. Among those tested, positive tests are still relatively rare, about 3 to 6%. And so overall, that means the diagnosis of gonorrhea or chlamydia in the entire population, whether or not they're tested, is 1 to 2%. About 40% of women are attending an annual Wellwoman exam. So adherence to that is less than half, so it's slightly low. And so these are kind of the outcomes we are observing in the data, and that's what our data looks like as we are starting to do the analysis. This shows it graphically as well, right? And we're going to look here at how LARC increases are tied to Wellwoman visits and STI tests. So as you can see from the graph, as over time there's been slight decreases in Wellwoman visits over time, and that's correlated just in the data with the increase in LARC adoption. So that left axis is portion of women with a Wellwoman visit or an STI test, and the right axis is the portion of the sample with LARC, right? So you can see these two trends. In terms of STI tests, there's a little bit less of a clear correlation. It does seem, though, that there's a slight declines in STI tests as well, right? And obviously, to have an STI test at the Medicaid data, you need the woman to be attending a Wellwoman visit or other office visit. And so there might be a relationship here. And that's, I'm trying to preview some of the results we'll be showing, right? That if women are never showing up for a Wellwoman visit, then we might have less STI testing just because those STIs are never tested for. Now this graph is going to look at how positive tests relate, and those positive tests are only for those with a test, and then the STI diagnosis is for whether or not they were tested, so among all women. So you can see this on the left axis is the portion of women with a STI, a positive test or an STI diagnosis. And the right axis is showing the sample with a LARC over time, right? So that blue line is similar to the last graph, and we're just looking at differences in diagnosis and testing. And here you see any STI diagnosis, doesn't seem to be much of a trend. But again, if this is regardless of whether or not they were tested, then we might be picking up the fact the STIs could be going up in the population, but if women are not necessarily tested, they may not know that they have an STI until they have more symptoms. So the green bar is also something to focus on. So among those tested, whether or not there are positive tests, and we see some maybe slight increases over time, although there's not a huge trend, right? And so we have less of a clear relationship in this regard. Okay, so here I'm going to start with the results for looking at Wellwoman visits, because I think it really helps to understand some of the results we may be finding in STI testing and STI diagnosis. So just to start with, right, we're going to look at LARC over time. And if we look at if we just look at people with LARC, then we see higher testing in that year. And again, that's associated with clinical guidelines that women should be tested. But if we look at LARC in the previous year, we might not see any difference. So first we want to see whether or not women are attending their Wellwoman visit. Right. And what we find is that after a year, then women are less likely to attend a Wellwoman visit in the following year. And this goes on for up to 3 to 5 years, depending on the actual type of LARC they're using. Right, so 1 year after LARC, compared to women using no prescribed method, they're about 7.5 percentage points less likely to attend a Wellwoman exam. Right? And that is compared to women using moderately effective methods here, who are only 1.1 percentage points less likely than women with no prescribed methods to attend a Wellwoman exam. And so after 3 years in the sample overall, we see that effect go away. So women tend to have a higher risk of missing a Wellwoman visit for about 3 years. If we break up LARC into implants and IUDs, we see that that is correlated with the type of LARC they used, and it relates to the type of or the effective length of that LARC product. And so what we think this means is that women are often attending their Wellwoman visits in order to renew their contraception. And so women using moderately effective methods tend to continue to attend their Wellwoman visits in order to get that prescription again. Whereas women using LARC may not necessarily be as motivated to attend their Wellwoman visit in the following year after LARC, because they can continue their contraceptive method without seeing the doctor again. Okay. Now we move into just LARC or testing, comparing LARC users to those of using other contraceptive methods, and this is all relative to women with no prescribed method. So in the year of that women had received their LARC, they are slightly more likely than women with moderately effective methods to be tested for STIs. And we identify this as that clinical recommendations are being followed, right? Because remember, most women should be tested upon LARC insertion. And so they are slightly more likely than other women to have their an STI test. And this is true for the sample overall. And then also when we break the sample into the younger group who have clinical recommendations to test, and the older group which have less of a clinical recommendation to test, absent other criteria. Right, so among the sample overall, about 18, they have an 18 percentage point increase in the probability of being tested compared to those with no prescribed method. And that is different than moderately effective methods, which only have a 14 percentage point increase compared to women with no prescribed methods. Then we look at the year after they receive LARC, and this is, again, we're going to refer back to our Wellwoman visit findings. So in the year after receiving LARC, overall, women receiving LARC last year have about a 4.3 percentage point decline in STI testing compared to women with no prescribed method. And this is true among women, the younger women group who have a higher risk of STIs just in that age group, and then compared to older women above 25 and over. And you don't necessarily see the same patterns for women with other contraceptive methods. So this again raises the question: are they making office visits? And so if they are not making office visits, they may not be tested according to clinical guidelines. Then we look next at STI diagnosis of chlamydia or gonorrhea. Right? And what we see is basically compared to women using moderately effective methods, they have similar risk of diagnosis. This is higher than women with no prescribed methods, but that may be because women with no prescribed methods may not be sexually active. So if we compare them to moderately effective methods who are also more likely to be sexually active than women using LARC, right, we see basically no difference in the probability of STI diagnosis. So in some ways it could be that the concern about women not using dual use methods with LARC there may be less of a concern because they have similar rates of diagnosis. Again, this is in the same year of LARC insertion, and so if they're being tested more often because of LARC insertion, we may be finding that they're getting less advanced STIs diagnosed, right? And that's something to investigate in the future. If we look in the prior year, whether or not women were received a change in contraceptive in the prior year, right? We see basically identical estimates for LARC and moderately effective methods. And so compared to women with no prescribed method, we don't see the concern again that we were initially worried about, that that lack of dual use is putting women at substantially higher risks of STIs. So in the future parts of this project, we're going to do a few things. First, we're going to analyze additional subsamples. So by race, ethnicity, we're going to look at women at potentially higher risk by whether or not they ever had an STI diagnosis in the sample. And then we're going to look at different Medicaid benefit groups to see if women at slightly different income levels, that's going to be our rough cut for income, whether or not they had if they look differently on these outcomes. We're also planning to incorporate the cost data. We've just got that into the data set, so we're going to look at the cost of STI testing, the cost of STI treatment, and the total STI costs. One other thing we're going to look at is because one of our findings was so strong on Wellwoman visits, is Dr. Marshall Lee has agreed to work with me to look at the specific programs or specific types of preventive care that women may be missing by not attending their Wellwoman visits. And so if we can really explore that more to see if women are missing preventive health guidelines, or if maybe they may be skipping their Wellwoman visit but still making another sort of visit for kind of from a general practitioner's, and so they may still be getting their cholesterol screening, or they still may be getting other preventive care that is going to improve their health in the long run. So that's something that we're really looking forward to incorporating this analysis, and we thank an Embry grant for allowing us to do that. So in conclusion, right, we find some evidence that women are visiting doctors for the routine Wellwoman visits primarily to refill, I shouldn't say primarily, an important reason women are attending their Wellwoman visit is to refill their prescription contraceptive method. And so LARC users, and in some other work we find sterilized women may be missing some of this routine preventive care. And so I think what women need to be better educated about the importance of preventive care and preventive screening and counseling in order for them to realize that they should be attending. We also find evidence that the clinical recommendations for STI testing are being followed, and so that is good news that women using LARC are being tested as the recommendations would suggest. That's it. So I'm happy to take questions. I would love questions, comments, and other suggestions from this group because you all know much more about me than some of these topics. So I will stop sharing now.
Thank you so much, Dr. Fitzpatrick, for this very, very informative presentation. Any questions?
I do have a question, if that's okay.
Hi, Karen.
Hi, how are you? Karen Antel. I'm a family medicine faculty at Christiana Care, and I work actually on doing a lot of the contraceptive education for various providers in our system. And so I love that you're looking at this because it's something that we've discussed and be like, why are we not looking at this? I remember being at a conference a few years ago at Nemours, and we were sort of asking these questions and saying these are things that people should be researching, and it's so great that you are. So that's wonderful.
Okay, thank you.
The question I have, I'm not sure, I'm trying to phrase it exactly what I want to say, but you know, it's a little bit confusing comparing women who had sterilization because they tend to be older. Legally, they have to be at least 21. In general, women don't have sterilization performed until they've completed childbearing. So usually almost always over the age of 25, which is when the CDC is no longer recommending annual STI screening. So I don't know that using them as a comparison population is all that instructive. I guess I just feel like it's a different population. If we're looking at younger women who are more likely to not be settled into a long-term relationship, are more likely to just by nature of being younger and maybe more sexually active, and also women who've completed childbearing and have a tubal ligation, have children at home that may be getting in the way if they're able to be as social and active as they might be if they were not. So I don't know. I just wonder about if that's really useful to have them in the comparison population, because it feels like it's a different set of patients. Does that make sense?
Yeah, no, definitely. Thank you. And we've been taking them out of and actually thinking about using them as kind of a separate paper to compare sterilized women to other women for looking at their use of healthcare. But when we take them out of the sample, nothing really changes. None of the effects are that different. I think because it's just a small portion of the population, especially when you look at the 15 to 24-year-old group, the kind of the younger group. So it's not a large portion of the population, but we have done analysis where we have removed them from the comparison group, and the results are hold, right? So the point estimates might change slightly, but none of the substantial conclusions are any different. But when we are breaking these up into papers to begin submitting, we are removing these women from a comparison group and thinking about them differently because, I think in the literature that we've reviewed, it doesn't seem there's been a lot of focus on sterilized women and their use of healthcare. So we're thinking about using that as a different paper and analysis to say, are these women at risks for different things, for STIs, or for just not being in the preventive healthcare system?
Right, because they may be more likely to be in need of routine health screenings that are not around STIs, like cholesterol and blood pressure and, and things that get into just general primary care screenings. So
yeah. Thank you.
It's really interesting. I'm
Thank
so
you.
excited to hear about it.
Great.
Any other question? Well, I have one question, Katie. Do you think you would see the same results, or have you considered also looking at women who are not on Medicaid but have commercial insurance?
That's a good question. And we obviously don't have that data. We've done some other work looking at the National Survey of Family Growth, and that's really to focus on kind of the dual use and whether women are using prescription and non-prescription methods together like we would expect. And the literature does find that LARC users are less likely than other users or other than moderately effective hormonal method users to use dual use. And we've been finding that as well in the National Survey for Family Growth, and that really varies based on age as well. But in terms of looking at kind of people in all insurance programs, so that would be women kind of at higher income, I think the results would probably about hold. I think there would be some bias where you would have higher income people that may be making more time for preventive care, right? They may not be juggling as many stressors in their life as the Medicaid population, and so they may be more likely to attend preventive care. On the other hand, women in higher income groups may face more costs associated with the use of healthcare, which may potentially reduce their use. So I think overall those might probably wash out, and I think you would find similar effects, but it would be an interesting a question to look at, and I think you would need kind of private insurance data, because I'm not sure any of the surveys out there have good data on both Wellwoman exams and all these LARC and moderately effective methods, but that's something to definitely consider in other surveys. Thank you.
Thank you. So, are you considering including results from census tract, the socioeconomic information that you can get from census tract in your next analysis?
We're not, just because that would require geocoding all the addresses, and we that would just take too much time and I guess computing power and staff power, because Mary Joan and Katie Gifford, they're the experts on this, and they do the extractions and they know the data so well. So what instead we've done is use that zip code, which is a lot easier to get from the Medicaid records. And because there's so much kind of homogeneity within zip codes, right? People tend to live near people that look like them and act like them, so kind of in a socio-demographic sense, that we feel like using those characteristics and in the analysis helps to control for some of that. Obviously, census tract would be a lot better because it's smaller and would better capture those characteristics, but I'm not sure it would be worth the cost in terms of the time it would take to geocode all those addresses. In a perfect world, we would love to do that, but I don't think we're able to do that with our resources.
Excellent. Well, thank you so much for this wonderful presentation, and I think we have other also topics that we can talk about as we discussed prior to your presentation. So we'll have you back.
Okay, great. Thank you so much, and thank you for having me.
Thank you. Bye. Thank you, everyone.